All right, hey everybody, I'm Tim Peters. I'm one of the hospitalists here, and today we're going to be learning how to read chest x-rays. So at this stage in your career, there are really just a few things that I want y'all to be able to do as you're coming back from your or back into your clinical years. One, I want you to be able to use the right language when you're describing a chest x-ray. Because really the number one job of being a third-year med student is to not sound like an idiot, which is going to happen every day. But if you can at least use the right words, you can mask that for a little bit longer. But so use the right language. Two, I want you to be able to pick out the most common things on chest x-rays. And then lastly, pick out the things you can't miss, even if they're not necessarily common, the can't miss diagnoses. All right, so here is our brief outline. We're going to talk about the technique of how x-rays are shot, and then we'll kind of review the anatomy of what the x-rays are actually capturing. And then we'll go over an interpretation method on how to read chest x-rays, and then lastly, we will go through a few examples. All right, so when it comes to chest x-rays, there are really kind of three different flavors. Far and away, the gold standard is what we call a PA and lateral film. And we'll go into each of these in a little more detail. But so you got the PA and lateral, and then you have an AP film, and we'll talk about the difference between AP versus PA. And then lastly, we have what's called a lateral decubitus film. So this is an example of a PA and lateral, or at least on this slide we have the PA. So the PA stands for posterior to anterior, which means the X-rays are being shot. So the actual x-ray machine is behind the patient here, and they're being shot in this direction from her posterior side into the anterior side, and then the actual film that is capturing the rays are in front of the patient. So it's aptly named, just describing the direction at which the rays are flowing. And then to the right on the presentation, this is an example of really the perfect chest x-ray. We'll talk about why it's so high quality, but this is what a PA film looks like. Now generally, PAs are almost always coupled with lateral films. There are a lot of advantages to lateral films, but the key thing is that it's going to expose anything here behind the heart or deep into the posterior sulci of the diaphragm, which you're not going to be able to get on a PA or a lateral film. Okay, sorry, a PA or an AP film. The lateral is the only film that's going to show you any opacities or pathology that's behind the heart. So now let's compare an AP film to a PA film. So they're opposite. So AP stands for anterior to posterior. Now this is not the same patient, so it's not a perfect representation, but it gives you a general idea of the differences in quality between an AP film and a PA film. Now most of your x-rays done in the hospital are actually AP films, and there's a few reasons for that. One, these can be done portably, they can be done quickly, and they can be done with patients lying down, or they are done with patients lying down. So to be able to get a PA film, patients have to be healthy enough to be transported from the unit to radiology. They can't be intubated. They have to be able to follow command, so they can't have any altered mental status. So there's a lot of reasons why we don't get a ton of PA films. They also take much longer. So kind of the take-home point here is that if the patient can tolerate a PA film, get the PA film, because it's going to be much higher quality. That said, probably 70% of films done in the hospital are AP. All right, so this is an example of a lateral decubitus film. Now, we don't use this type of film near as much because we use chest CT so often, and even in the last 5 to 7 years or so, we're doing a lot of chest ultrasounds, but lateral decubitus films were great at evaluating pleural effusions, and so they could help determine if effusions are loculated or free-flowing, which often will dictate how you manage them. And so, like I said, now that we have CTs and they're so quick and easy to get, I don't think I've ever ordered a lateral decubitus film, but that you need to know about them. The other thing is that most patients that have an effusion the size of this one you see here these patients are going to be really short of breath. They're not going to be able to tolerate laying like this, and they're probably, or odds are, they're going to need to be on oxygen as well. So there's a lot of limitations, and so that they're not done that often, but they can be helpful in certain situations. Okay, so let's talk about the technical quality of the film. There are a lot of different ways to assess the technical quality of the film, but the three that I want you guys to know about is penetration, inspiration, and rotation. So penetration is also known as exposure, but let's look at these. So penetration has to do with how many of the x-rays are making it through the material that you are imaging, okay? And so it's directly proportional to how dense it is. And so if a material or a tissue is more dense, that means it's harder for x-rays to get through that tissue to actually make it to the film. And those denser tissues will show up as white or whiter on film. Whereas if a tissue is not very dense at all, the x-rays have no problem penetrating it. They make it to the film and they appear black on a developed film. And so radiographically, when it comes to x-rays, there are really 5 densities that you need to know about: metal, bone, water, fat, and air. And it's helpful to know, to at least have a general idea of the colors that these different tissues will give you on an x-ray, because it can often help figure out exactly what you're looking at. Again, if you contrast the bright white metal, which no x-rays can penetrate, to air, which is almost black, that this all has to do with the density of the tissue and how much of the rays can make it through. So when it comes to determining is a film properly penetrated or properly exposed, there's a couple of different things that we look at. The easiest thing to determine is glance at the ribs behind the heart. You should just be able to barely make out ribs behind the heart, and if the ribs are too prominent or you can't see them, then the film's either underexposed or overexposed. The other thing that's important is kind of glance at the periphery, anywhere in the lungs near the periphery, and you should see lung markings extending all the way out. So you can clearly see lung markings here going all the way out to the periphery. Again, you're not going to see that if the film is not properly exposed. We'll look at some more examples, but those are the 2 easiest things to pick up on. So here are some great examples of an underpenetrated film on the left and an overpenetrated film on the right. Again, penetration is referring to how many of the x-rays can make it through the material. So if you have a lot of x-rays that aren't able to make it through the material that you're imaging, it's going to appear more white on the x-ray, like we talked about. And the opposite is true for overpenetrated. You have too many x-rays going through the tissue. Now, a lot of this we kind of can work around, given that everything's done digitally now. But before we were all digital, many x-rays were almost completely useless if they were not properly exposed. So let's talk about the things that are obscured when the film's not properly exposed, or things that are altered. So if you look at the underpenetrated film, so you cannot make out any ribs behind the heart. So that's your first telltale sign. And also you cannot see any vertebrae below the diaphragm. So both of those things tell you that the film is probably underpenetrated. And what that does is a couple things. One, it accentuates the degree of normal findings. And so what I mean, look, the big thing here are these pulmonary vessels. And so these pulmonary vessels are much more prominent if the film is not appropriately penetrated. And so whereas if this was a normal film and you had big, large pulmonary vessels like that, is probably pathological. But in this case, we don't know if it's due to pathological abnormality, or is the film just not properly exposed. The other thing that an underpenetrated film will do is it will obscure the bases of your lungs and make it nearly impossible to rule out or evaluate for any effusions or any other basilar lobe abnormalities. So you don't get a good view of the bases, and the normal vasculature architecture is abnormally enhanced if the film is underpenetrated. Now let's compare that to the other one here on the right, where it is overpenetrated. And if you look behind the heart, the ribs are very prominent, and if you look at the vertebra, you can see them way beyond the diaphragm. So that tells you that this film is overexposed. And what that does is it pretty much makes any lung pathology impossible to identify. Your lungs are nearly blacked out. Okay. All right, so the next thing that we need to evaluate when it comes to the technical quality of the film is inspiration. And this refers to if the patient or the film is timed at the proper moment in the respiratory cycle, and so you want to capture the film at the moment the patient has maximum inhalation, so it expands everything. So the easiest thing to do in determining if there's proper inhalation is to count your ribs. So you should be able to relatively easily count 10 ribs. Now I don't count ribs on every film that I look at. You kind of get a feel for it over time, but the gold standard is to be able to count 10 ribs. Okay, and let's look at an example here. So this is the same patient, and you can ignore the red arrow. The red arrows. What I want to focus on is this ICD this patient has. So if you look at the image on the left, this film was taken at the end of exhalation, and you can see the ICD battery is looks like it's almost touching the border of the heart, whereas the film on the right, the ICD battery, is almost completely in the soft tissues, which is where it truly is anatomically. And so I don't care so much about ICD in particular, but what I'm showing you is how things can drastically change depending on when you capture the film during the respiratory cycle. The other thing that this does is, if we go back to penetration, if you capture a film at the end of exhalation, so you got your alveoli in your lungs that are slowly exhaling, getting rid of all that air, and then the alveoli collapse, and so now you have dense alveolar lung tissue, which is going to be more white than alveoli filled up with air. And so that's the reason, if you look at the image on the left, that this is the same patient taken 2 seconds apart, that the patient's right lung on our left side is much more white compared to the x-ray on the right. And nothing's changed pathologically or clinically. That's just the difference between alveoli that are open and alveoli that are collapsed. All right, so let's talk about rotation. So another thing to always keep in mind, and I'll mention it a few times during the lecture, is chest x-rays or any x-rays are two-dimensional images of three-dimensional patients. And so there's going to be some distortion, and you need to keep that in mind. So if a patient is rotated, then it's going to alter what the film looks like. So the easiest way to tell if a patient is rotated or not is to look at the medial ends of the clavicle, and each one should be equidistant from the spinous process. So here's our spinous process going up, and there's one medial end of the right clavicle and the other medial end of the left clavicle, and they're essentially equal distances apart. So if a patient is rotated, there's going to be a drastic difference between how close each clavicle is. Okay, so when it comes to the penetration and the inspiration and the rotation, this will be something that you do really quickly. As soon as you look at a film, you're going to be able to tell is the technical quality where I want it. And once you've assessed that, you move on to the next part. So let's briefly kind of look at our anatomy. One thing that attendings love to pimp students on is the chambers of the heart when you're looking at an x-ray. So remember, the apex of your heart is rotated posteriorly, and that's why your PMI is way over here as opposed to being more anterior. And so when you're taking that two-dimensional image on an x-ray, the majority of what you're actually visualizing, so this whole area here, is actually all right ventricle. Okay, so intuitively, we would probably call this the left ventricle if you weren't thinking about it, but most of what you see of the heart on a chest x-ray is actually the right ventricle. And then you can see the right atrium up here the left atrium. And then this little sliver is really your left ventricle. So even though that makes up the majority of the heart when it comes to mass, most of it's posteriorly oriented, and so you're not seeing it much when you're just looking at an AP film like this. Again, X-rays are two-dimensional images of three-dimensional objects, and that's really really noticeable when you start looking at the shapes of the lobes. And so if you look at the right lower lobe here, it almost looks like this should be a cube shape, but when you take a lateral film, you can tell it's actually very oblique. Same applies to the right middle lobe. And so, and we'll glance at the left side, which is similarly oblique. It's important to keep this in mind when you're trying to localize where something pathological may be. If you're just looking at a AP or a PA film and you've got a lesion here, you cannot tell if that's in the lower lobe or the upper lobe. Okay, so that's where the lateral film is really helpful. Okay, so let's talk about how we actually interpret films. There are a lot of different ways that you can read about online. The method that I like is the alphabet method, or the A, B, C, D, E, F method. And the reason I like that is because it saves the thing that your eyes immediately want to go to, the lung fields, to last. That way you're kind of forced to go through all the smaller things that you don't want to miss leading up to the meat of the X-ray. But regardless of what you do, be systematic. I still, when I'm looking at an X-ray, I'm going through my ABCs, because if not, you're going to miss something. Okay, now, if you're at a big, busy hospital, you're going to have radiologists always available. But a lot of us may be working at smaller hospitals or rural settings that you're not going to have a radiologist until the next day at 8 o'clock in the morning or until Monday. Even at UAB, a lot of plain chest X-rays are not read until Monday. So you need to know how to go through it yourself, regardless of what specialty you pursue. So we'll kind of go through each of our letters here, and for every letter, it stands for something that you want to look at on the film. And for each of these examples, there's a major abnormality with that particular thing that we're evaluating here. So this is usually where it gets a little more interactive, but if you're looking at the slide here, the major abnormality that your eyes may initially go to is this whole whiteout over here. And this is a hemothorax, and so the A stands for airway. Okay, so you can see this airway is pretty significantly deviated from left to right because of the hemothorax. The airway should be running down the vertebra if the patient's not rotated. Okay, remember hemothoraxes exert positive pressure on the trachea, pushing it contralaterally, where if this was a pneumothorax, it's exerting negative pressure until it's going to pull it ipsilaterally. So glance at your airway first. Okay. All right. B. The B thing. I'll give you guys a second to kind of look at it to see if you can see something that's grossly abnormal that starts with the B. But we always kind of glance at your bones. So this patient has a pretty significant right-sided clavicular fracture. Some or a lot of fractures are not this obvious, especially rib fractures. But what I generally do is I'll look at my clavicles, look at the scapula if you can see them, look at the heads of the humerus, and then glance through your ribs. But like I said, unless it's big, odds are you're going to miss a rib fracture unless you're a radiologist. Okay? But what you don't want, if a patient comes in short of breath for whatever reason, you don't want to miss a fracture because you're looking at the lung field. So go through everything systematically. All right, so B was bone. C stands for cardiac. So let's see. Okay, so I like this image because this is where I usually ask you guys what kind of surgery you think this patient has had. But you can see several sternotomy wires here, okay? And then this patient also has a mechanical mitral valve. So this is a patient who's had an open mechanical valve replacement. The other thing you want to look at when it comes to the heart is to try to determine if there's any cardiomegaly. So the easiest way to do this is to measure the width of the heart and compare it to the width of the thorax. And if it's above 0.5, you have cardiomegaly. So again, I'm not getting out my slide rule every time I look at an X-ray, but you can kind of glance at this. This patient has pretty significant cardiomegaly here. Okay, so this is another thing that you guys don't want to miss. This is a classic water bottle sign, which can happen when you have a large pleural effusion, large pericardial effusion. Generally, you're going to know about this before you have a chance to get the X-ray. This patient is probably going to be critically ill, and there will be obvious signs of tamponade, and a bedside echo is going to be quicker than an X-ray. But the water bottle sign is kind of this globular shape of the heart that can happen as fluid builds up around the heart. All right, so D, there's something that's really easy to miss, and once it's pointed out, it's obvious, but something that you cannot miss is air under the diaphragm. This patient has a large amount of air here on the left side and a little bit here on the right side. So this generally happens if you've had some type of GI organ that is ruptured. These patients are critically ill. You're not going to miss it clinically. Their belly is going to be hard as a table, and they're going to be very, very ill. But the reason I point that out is because you don't want to confuse this with air into the diaphragm. So this is a gastric bubble, okay? And this will be on the majority of X-rays. So you don't want to freak out over just a little bit of gas in the stomach. And the ways to tell these apart is, one, if it's a gastric bubble, you shouldn't have anything on the right side. And two, you're going to see, generally you're going to see an air fluid level compared to this, where you see the air extends all the way down. Here you got this pretty sharp air fluid level laterally. Okay. E stands for a couple things. One is effusions. You want to evaluate every patient for whether or not they have an effusion. So this patient has this concave shape of his diaphragms because he has relatively small effusions, but they're there. So if you compare that to a normal chest X-ray, you can see the talon-like shape of each diaphragm as the lungs expand all the way down. Okay, so if it's this concave shape, there's going to be that's an effusion. Okay. E also stands for everything else. What I mean by that is anything that's not a part of the patient. And these things are going to be important to know about because you're going to need to determine proper placement of a lot of different devices. So we'll kind of go through these real quick. So these arrows here are pointing to telemetry wires. Okay. This arrow here is pointing to a CVL. So this patient has a right-sided internal jugular central line that goes in and the IJ and then terminates up here just above the right atrium. But when you have patients with CVLs, or after you place a CVL, you need to make sure that they're appropriately placed. And so if it's too shallow, if the tip of your CVL is too shallow, it can come out. If it's too deep, it can induce arrhythmia. So you want it to kind of terminate right at the tip of the right atrium. The other thing you got to make sure of after getting a CVL placed is that there's no pneumothorax. So check for proper placement and check for a pneumothorax. The one last thing I want to point out here is this endotracheal tube. So again, as an intern, you'll probably be asked to confirm appropriate placement of a ET tube. Again, you don't want it too shallow, you don't want it too deep. If it's too shallow and it ends up here, a patient can cough it out. If it's too deep, you risk doing having a right main stem intubation. So generally, you want the very tip of the ET tube to be in line with the clavicle. So this one's pretty perfectly placed. The other thing that you'll need to confirm placement on is nasogastric tubes, and the important thing here, you want to make sure they're not in the lungs. So the tip of the NG tube has to be below the diaphragm. It seems pretty obvious here. There are a lot of times where it's not so obvious and you need to reposition the NG tube. What you don't want is this, where the NG tube is clearly going into the lungs. If you start tube feeds on a patient with this, odds are you're going to kill them. So if the NG tube was properly placed here, So you can see the diaphragm here, you can see the gastric bubble here. I would want the tip of the NG tube to at least be down this far. So most patients are going to be symptomatic if you've got an NG tube in their lungs, but not all of them. So it may not be so obvious. If there's any doubt, reposition it and take another film. And then lastly is lung fields. We'll talk about that, but after we kind of review this. So again, remember to be systematic. Work your way through your ABC. So look at the airway, look at the bones, look at the heart, diaphragm, effusions, everything else, and then lastly, look at your lung fields. Okay. So for this first example, we're going to go over everything from the technical quality of the film all the way through our entire interpretation, just as a point of learning. And then I've got several other examples that we won't go as in-depth in just for the sake of time, but I want to spend a little bit of time on this first one. So first, let's talk about the, so let me back up. There's a big honking abnormality here on the right side. Your eyes immediately want to go to that and be done with it. So fight that urge and let's go through it properly. So first thing you want to do is assess the technical quality. So is it properly exposed? Are the x-rays properly penetrating it? So again, you can see the ribs are barely visible behind the heart, okay? And you can see lung markings going all the way out to the periphery of the lung. So that this film is appropriately penetrated. The next thing you want to look at inspiration. So this is actually a child, and so it does affect the number of ribs that you're counting, but I believe this patient actually does have 10 ribs. So we'll count our ribs here. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 ribs are visible. So this patient is appropriately inhaling. And then lastly, for technical quality, you want to look at rotation. So again, look at the trachea, which is here. Now, this is a child, as I mentioned, and so the medial ends of their clavicle have not fully formed, and so they don't have a nice squared edge like adults do. But you can see the edge of one here, and looks like the edge of one is about there. So this patient may be rotated just a little bit from left to right, but because the left side is closer than the right, but otherwise this is a pretty good technical quality in terms of technical quality. This is a good film. So now let's start working through our so let's start working through our alphabet. So again, look at the airway. I'm not seeing any deviation here. Airway otherwise looks okay. Glance at your bones for B. Again, this is a kid, so you're going to get a bigger view of their bones, but glance at the clavicles. I don't see any fractures there. You can see the heads of the humeri. Those look okay. Now you know it's a kid because he's got pretty significant growth plates at the heads of his humerus there. And as I mentioned, his clavicles haven't squared off yet, so those are kind of dead giveaways. But look at your humerus, look at your scapula. Glance through your ribs. The ribs look okay, so I'm not seeing any major abnormality in terms of bones here. Move on to C, which is cardiac. So I'm not seeing any obvious effusion. The ratio of his heart to the thorax is well below 1/2, so no cardiomegaly. D stands for diaphragm. There's no air underneath either of these diaphragms. You can make out a subtle gastric bubble here, but there's no air under the diaphragm. E, let's look for effusion. So on the left side of the patient, you've got a nice sharp diaphragm, so no effusion here. There's a little bit of blunting, a little bit of concavity here on the right side, which is probably related to this big pneumonia, and so he does have a mild right-sided effusion. The other E, everything else, I'm not seeing any external stuff. And then lastly, our lung fields. He's got this large right-sided opacity that's consistent with the pneumonia. Remember, like I said from the beginning, there's no way you can tell just based off this image if it's in the right lower lobe or right middle lobe. Okay. Okay, so this patient, we're not going to go through everything, but this is not a very good film in terms of technical quality. This is underpenetrated, but it does show what I want to talk about. So the clinical vignette that you would have for a patient like this is going to be a 54-year-old male that comes in complaining of dyspnea on exertion, lower extremity edema, P and D. and this is a classic heart failure picture, okay? And this patient has pretty bad pulmonary edema. So go back to our densities. If you have pulmonary edema, you have extra fluid and blood throughout the lung fields. And so fluid or water is more dense than alveoli filled with air. And so that's why you get the white lung markings in pulmonary edema, is from just the water being more dense than air. The other thing about pulmonary edema that I want to point out is that it's usually gravity dependent. And so generally, if you look up here, it's a little blacker than this down here, and same here on the right side, because the fluid is gravity dependent and it's going to be worse than the bases. So you can tell that on your physical exam. It's pretty unusual to hear crackles in the apices of CHF patients. Sometimes you do, and generally those patients have really bad heart failure, but a lot of times it'll be clear in the upper parts of the lungs, and that's because it's gravity dependent. And I wanted to point that out because what pulmonary edema is often mistaken for is pulmonary fibrosis, or I should say it the other way around. Pulmonary fibrosis is often mistaken for pulmonary edema. Pulmonary edema is extremely common. IPF is not that common at all, but they do look similar at first glance. So the way you tell these apart, one is IPF should not be gravity dependent. The upper part of the lobes will, or the lungs will fibrose just like the bases. And so you can see here, the irregularity is pretty consistent from the bases all the way up. This patient also has pretty sharp diaphragms, which a CHF patient doesn't generally have, because they almost always have at least mild effusions. So IPF is not gravity dependent. And the other thing is, and the more you see, this will be obvious, but the abnormalities are much more fine and reticular in IPF. So these are a little more coarse, where, especially if you kind of look up in here, that this is a classic example of an IPF finding. But at first glance, they do look similar. Now, obviously, your clinical history and probably your body habits are going to be very different between these two patients. And so when you take the whole picture into consideration, it'll be more obvious. But just looking at a film, IPF does look similar to the pulmonary edema. So this patient, if this was a test vignette, it would be something like a 59-year-old gentleman with a 40-year-old pack, a 40-pack year history of smoking, comes in complaining of shortness of breath. This is a classic COPD patient. So remember, COPD is an obstructive lung disease, which means they have difficulty getting air out. And so they can get the air in just fine. They fill up these alveoli, and they can't get that air out. And so again, air is less dense, and so it gives you this broad, darker X-ray, just because there's so much air in these patients' lungs. A few other things to point out is, this patient has relatively flattened diaphragms. Again, that's because they're really using their diaphragm muscle to try to contract their lungs to get that air out. And so over time, you'll see these flat diaphragms. The other thing is, at first glance, his heart looks kind of funny, but the reason for that is if your diaphragm is not flattened, the heart generally rests on it. If you have COPD and you have hyperexpanded lungs, your heart isn't able to rest, and so it more dangles. And as it dangles, it rotates more posteriorly. And so a lot of times, I've seen X-rays where you don't even see a heart because it's in line with a vertebral column. But you can see this guy, it looks like he has a really skinny heart, but it's just because it's not resting on that diaphragm. Okay. So the history you'd get with a patient like this would probably be a passenger in a vehicle that got T-boned in a motor vehicle collision. And so they've got a large hemothorax here on the right side, causing almost a complete whiteout. As we mentioned earlier, you can see the tracheal deviation going from right to left. Often contrast that with a pneumothorax, which you see here, and your clinical vignette here will be like a 19-year-old really slender male that suddenly gets short of breath while playing basketball or something. But his entire left upper and left lower lobe is all concentrated right there. So this is all just air. So he's got a very large pneumothorax here. And trachea actually looks pretty midline here, but generally, as I mentioned earlier, you're going to see this ipsilateral deviation of the trachea. Clinical story here is going to be, you know, a 50-year-old homeless gentleman that comes in with hemoptysis, fevers, chills, and productive cough. He's got a big old cavitary lesion, okay, consistent with TB up here. And then lastly, this is a lung cancer. And so unfortunately, most lung cancers are not this obvious. Very, very few are this obvious, but a lot of times these are confused for pneumonia, and clinical history doesn't always differentiate these two, because a lot of lung cancer patients actually present with a pneumonia, so it gets challenging. But one of the easier ways to tell the difference is generally the mass will have very sharp edges, you know, compared to, go back to our pneumonia patient, the borders of the opacity. See, this is not well defined at all. I mean, you can tell where it is, but there's not clear margins between pathology and healthy lung tissue. Whereas on your the lung cancer picture, you've got pretty sharp margins all the way around. Okay. And I think that's all I got. So if you have any questions, please email me, and I'd be happy to answer them.